Okay. Are you able to see my presentation?
Yep.
Okay. And sounds okay? You can hear me? Okay. So like Jason said, my name is Andrea Fong. I am a pediatric allergist located here in Regina. And thank you for asking me, as well as Melissa, to speak today about penicillin allergies and a risk assessment delabeling tool. So I don't have any disclosures or conflict of interest with this talk. Our objectives for this presentation today, we hope that by the end of the presentation that you're able to define what a drug allergy means, the different types of drug allergies, and the different types of drug allergy testing that are available and when each one would be useful, to list questions that should be asked when assessing a drug allergy, and to become familiar with the first-line penicillin allergy delabeling tool that is now available to all healthcare providers here in Saskatchewan. So penicillin allergy, why do we care? About 10% of the general population will self-report a penicillin allergy. And so people who report a penicillin allergy, whether it's true or not, are more likely to be treated with less effective or more toxic and or more expensive antibiotics. So just that in and of itself, we know that increase the costs potentially to the patient and definitely to the healthcare system. When we use medications, that's not the best option for the infection. That can lead to antibiotic-associated infections and resistance. That can lead to longer hospital stays and increased mortality. So who is actually allergic? When I first started my training about 10 years ago, the statistic was that about 90% of people who report penicillin allergy are actually not allergic. And even at that point, that was mind-blowing to me that there are people walking around with a medical diagnosis of which 9 out of 10 people actually don't have that. Since then, there's actually been more studies coming out that actually show that there's probably even more than 90%. Now we're quoting 95% or greater of people who report a penicillin allergy are actually not allergic. And so penicillin allergy assessments, but also delabeling, benefits the patient, public health, and the healthcare system as a whole. And what we will try to emphasize is that the reaction history, just like any specialty or subspecialty medicine, the history is the key part in guiding the diagnostic and the management approach. So to take a few steps back, I think wording, definitions are important because I think we are in this situation because often we are not on the same page about what we mean when we say somebody's allergic or that they have a drug allergy. So a big umbrella term is adverse drug reactions. So that's the big umbrella term for any time somebody has any reaction or basically an adverse reaction, something that they didn't want to happen. So type A reactions are related to the known pharmacologic effects of a drug. They're dependent on the dose. They're predictable, generally mild to moderate, especially if they came to market as safe for the general public. And they account for the majority of adverse drug reactions. So an easy way to remember this is these are known side effects of the medication. So especially common ones, we counsel people before they take a medication and what to look out for. Type B reactions are not related to the known pharmacologic effects of a drug, that it came to market, and for most people, we don't predict that this is going to happen. They're unpredictable. They're dose independent, meaning that it can occur even at really minuscule doses. And they generally account for a smaller proportion of adverse drug reactions. And that's what we'll be focusing on today. As we talked about, the term allergy, unfortunately, can mean different things to different people. So to the public, I feel like as an allergist, any adverse reaction to a drug gets labeled as an allergy. What a drug allergy, in its most simplest term or definition, is it's an immune-mediated, meaning your immune system is involved, adverse reaction to a drug. And so not all drug reactions involve the immune system. So when we use the term drug allergy, it implies that the immune system is involved. This is the classic classification of allergic drug reactions. So it's not just anaphylaxis that can cause an allergic drug reaction, although that is what we'll be focusing most on today. There are 4 types of immune reactions. The mechanism are different, how they manifest are different, and the timing is different for all 4. As I mentioned, we'll focus most on type 1 or IgE mediated or immediate reactions. These are the reactions that lead to anaphylaxis. In layman's term, I often call it the classic allergy because that's what most people, when they think they're allergic to something, that's what's going to happen. The other one that I'll mention a bit more about, just because I think I would say it's probably the second most common, not necessarily the second most common, but these type of reactions often get mislabeled for the type 1 IgE-mediated reactions, or at least that's what either the healthcare provider or the patients or their families, that's what's actually happened, but they believe that they have the type 1, that they have anaphylactic reactions to this medication. And so just looking at those two boxes, you can tell that the timing varies, right? So the IgE-mediated reactions happen within minutes, whereas typical type 4, they're what we call delayed reactions, typically happen a couple days after drug exposure. What makes it unfortunately confusing is that type 4 reactions can be very mild, so just a simple rash that happens a few days later, to severe reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis, which is life-threatening. Another graph that I like to put up is just to kind of emphasize that not all reactions are your IgE-mediated or classic allergies, but often they get lumped in together, is a chart that looks at common antibiotic and antibiotic families, the typical intolerance prevalence, like what reported prevalence, self-reported prevalence is, and the likelihood of actually having a classic or IgE-mediated allergy versus that delayed T-cell mediated hypersensitivity. And then the last column, the intrafamily immunologic cross-reactivity, just talks about if you're allergic to penicillins, are you likely to react to other penicillins like amoxicillin, or is that not likely? So common, unlikely, or we don't know yet. So I just wanted to draw your attention to penicillins and cephalosporins. So penicillin is the most common reported drug allergy. It is possible to have IgE-mediated allergy. It is also possible to have delayed hypersensitivity. And if you are allergic to penicillins, you are likely to react to other penicillins. So we generally tell people if you're allergic to one, to avoid the whole group. Whereas cephalosporins, not as common just in terms of an actual prevalence of an allergy. It is possible to have an IgE-mediated allergy, and it is possible to have delayed reactions, but thankfully, if you're allergic to one, often we can find other ones that are in the same group that you may not react to. Sulfonamides or sulfas is the second most common reported adverse drug reaction. But these don't cause and rarely cause IgE, I won't say don't, but rarely or unlikely to be causes of IgE-mediated allergies. They are more likely to cause T-cell mediated hypersensitivities, but yet often it gets lumped in the same category as all the other drug allergies. And most people, when they get labeled this allergy, they're worried about the next time if they get it, if they're going to have a classic or anaphylactic type reaction, when in fact that mechanism for a adverse drug reaction is actually not common to begin with. So what are some risk factors for people to actually develop an allergy, a drug allergy? So the higher the dose, the route matters. So IV routes versus oral, large molecular weight agents, frequent or repetitive courses. So are patients with chronic medical conditions requiring multiple courses or repetitive courses of antibiotics are at increased risk for actually developing an allergy. The duration of previous courses, so long courses are more likely to cause, put you at higher risk. If you are female, what is important to note is family history is not a risk factor for IgE-mediated drug allergies. We have patients or family members who come to us and say, grandma was allergic, so that's why I haven't taken it. So it's important to know that family history is actually not clinically relevant when, in terms of increasing somebody's baseline risk factor for having a IgE-mediated or classic drug allergy. Atopy, or just having a pre-existing allergic condition like asthma, eczema, environmental allergies, is generally not a risk factor either for most drug allergies, with the exception of people who have adverse reactions to latex and radio contrast media. So the last part of my presentation before passing it on to Melissa is just going through what allergy testing is available and just kind of knowing which one is useful. So we'll start with skin testing or prick or scratch testing and intradermal testing. So skin testing, is only useful for IgE-mediated reactions. So it's not useful for your delayed reactions or your type 2 or type 3. It's only useful for type 1 IgE-mediated allergic reactions. Patch testing or delayed intradermal testing. In studies, it's being looked at to see if it might be useful for certain delayed hypersensitivity reactions, so your type 4, but the evidence is quite low to use this as routine practice. An allergy challenge is a gold standard to confirm or rule out a drug allergy, and that's when we give a small dose of the medicine or the antibiotic in question under medical supervision to see if the patient reacts. And this is offered, and this is important to remember, that this is only offered when we deem the patient to be low risk. We've done a history plus or minus allergy testing, further allergy testing if needed, to see if this patient is deemed to be low risk to react. And then that's when we offer this small dose under medical supervision. And lastly, desensitization. It is a process that induces the temporary tolerance to a drug. This is offered when the drug is needed and there is no acceptable alternatives and the patient is deemed to be high risk. And so based on the history, plus or minus further allergy testing, if the patient absolutely needs this medication to treat their medical condition or infection, and there's no acceptable alternatives, this is a way that we can temporarily help basically train the immune system to tolerate this medication while they need it to complete the antibiotic course. The key thing to know is this, at least at this point, is a temporary tolerance, meaning when you're on the desensitization process, you can tolerate the drug, but once you stop, even if it's a medication you were supposed to take lifelong, if there's been a stop of a day or two, you can revert to being allergic and in fact have an allergic reaction the next time you take that medication. So once again, going back to who is actually allergic, greater than 95% of people who report penicillin allergy are actually not allergic. And another important point to remember is those with proven IgE-mediated penicillin allergy, if they've been avoiding for more than a decade, there's a good chance that they are no longer allergic. So even if they are appropriately labeled to be penicillin allergic, it should be reassessed at least a decade after they've had the reaction or confirmed to be allergic, just to see if they still are allergic, because it is something that you can potentially, quote unquote, lose or outgrow. The second point I want to bring up is that, especially in pediatrics, the majority of rashes that we see when kids are on antibiotics are actually related to the infection itself. So most of us get viral infections, same with kids. Most of the rashes that we see in kids are actually caused by the infection itself. Sometimes it's a combination of the infection and the medication, such as the common, if you were infected with EBV, which is what causes mono, and it's mistaken for strep, and then you're prescribed amoxicillin, over 90% of people are going to break out in a classic, what we call morbilliform rash or measles-like rash, all over your body within the first week of taking that medication. So unfortunately, I feel like there's two groups of people that I see for penicillin allergy. One, like kids who have had recent reactions, but then also adults who have been avoiding since they were a child because of these rashes or a rash that they had when they were a child, and they've been avoiding for decades until unfortunately they need that medicine and there's no other alternatives. So we're trying to make a case that this is important to actually assess, because this is, I can't think of any other medical condition where 9 out of 10 people actually don't have it, right? And the implications of being labeled penicillin allergic when you actually don't have it has impacts on the patient, our public healthcare system, and other people when you start to develop antibiotic resistance, right? The medications that we want to work no longer work as well because we've created this resistance by overusing other antibiotics. And so we want to emphasize that actually taking a history, asking those key questions is a key in guiding the diagnosis, but also how you manage it in the future. And with that, I will pass on the rest of the presentation to Melissa.
Thank you, Dr. Fong, for your portion of the presentation. I'll just go ahead and share my screen. Can you guys see the presentation okay and hear me okay? Awesome. Thank you. So as Jason had said, my name is Melissa Kucey, and I am one of the antimicrobial stewardship pharmacists here in Regina. And for my portion of the presentation, I'll be talking specifically about the penicillin allergy delabeling tool. So as Dr. Fong had mentioned, we know that about 10% of the population report having an allergy to penicillin, but the reality is that less than 1% of the population have a true or classic allergy to penicillin. And we know that patients who report having allergies to penicillin, that often leads them to receive unnecessary broad-spectrum antibiotics, which increases harm to the patient and increases costs to the healthcare system. And so the most important thing that we can do as clinicians is to help with reassessment of those allergies. And in order to do that, we need to be taking a comprehensive history, essentially, for that proper evaluation. So asking the patient questions such as, what were the symptoms that they experienced? What was the timing of the reaction? Trying to determine, was this an immediate hypersensitivity reaction or was this a delayed hypersensitivity reaction? How long ago did the reaction happen? So we know that in patients with a true IgE-mediated penicillin allergy, the longer they go without being exposed to a penicillin, the more likely they are to have lost that allergy. How was the reaction treated? So trying to gauge the severity of that reaction. And then, has the patient tolerated similar antibiotics since the initial reaction? And there are very useful, helpful tools that essentially can guide these questions and help with that reassessment of those penicillin allergies. A particular tool that I want to highlight today is the Penicillin Allergy Delabeling tool available on First Line. For those of you who aren't familiar with First Line, it is an app or a website that has a lot of great infectious diseases and antimicrobial stewardship related resources. It has a lot of local practice guidelines on there, and it also has all of our local antibiogram data on there as well. So it's important when you're wanting to know what your local resistance patterns are in your area. You can go on there to find some of that information. There are other also very useful tools, specifically the Penicillin Allergy Delabeling tool is available on First Line. Now, this tool was created by a group of allergists out in BC who essentially acknowledge that penicillin allergies are an issue everywhere, and they also acknowledge that clinicians might not be comfortable reassessing those allergies, and even when clinicians are asking the right questions and collecting the right information, they might not know what to do with that information. And so this group of allergists wanted to create an easy-to-use point-of-care risk assessment tool that was available to all clinicians that would essentially guide or help risk stratify patients reporting an allergy to penicillin. And so if you go into the First Line app and you click on Guidelines, you can scroll down to the Penicillin Allergy Delabeling tool. And you click on that tool, and it essentially walks you through each question that you would ask your patient. And it's very easy, straightforward to do. It takes maybe about a minute to kind of go through all the questions that you would ask your patient. And at the end of the questions, it essentially risk stratifies the patient. So it will identify, based on the information that you provide, it will identify the patient as either being very low risk of having a true penicillin allergy or more moderate to high risk. And really anyone above very low risk, it will just stop you right there and flag you and say there's a possible allergy, refer on to an allergist. So really this tool is to help identify patients being very low risk of having a true penicillin allergy. If your patient is found to be very low risk of having a true penicillin allergy, it will instruct you to either delabel that patient right then and there based off of the information that was provided, or if you as a clinician are needing further reassurance, or if the patient is needing further reassurance that they can safely take penicillins, you could also offer them an amoxicillin test dose challenge, and it walks you through how to do that. In this particular test dose challenge, It's essentially for adults, you give them a dose of amoxicillin, and then you monitor them for up to an hour after they have taken the dose to make sure that they don't have any reactions. This is a very safe practice to do in patients who are found to be low risk of having a true allergy. Most of the time, patients don't react and they tolerate the dose just fine. In some cases, usually less than 5% of patients will have a minor reaction, such as a rash or something that can be easily managed with antihistamines like Benadryl or Reactin. I've read a lot of papers where amoxicillin test dose challenges have been provided to low-risk patients, and I haven't come across a single paper where the patient had an anaphylactic reaction, assuming that they were low risk when they did the amoxicillin test dose challenge. So this is a very safe practice, and it's something that we do here in hospital when we're trying to delabel patients. So this is what that would look like at the end of that questionnaire. It would identify the patient as either being very low risk, and as I said, it would say, you know, you can go ahead and delabel, safely prescribe penicillins again, or if you want to do an amoxicillin test dose challenge, that's also an option. Anyone higher than that, so moderate to high risk, it'll stop you there and say, avoid penicillins for now, refer on to an allergist for further testing and assessment. So if you get to that point where a patient has a possible allergy, even in patients who are reporting an anaphylactic reaction to a penicillin, you don't necessarily need to avoid all beta-lactams to treat an infection. So if you have a patient who had an anaphylactic reaction to amoxicillin, for example, and they're now back in with an infection where a beta-lactam is the most appropriate option to treat that infection, you can still use other beta-lactams as long as we're avoiding beta-lactams that have a similar side chain to amoxicillin, if that is what the patient reacted to. And this risk stratification chart is also another tool available on the First Line app. So this kind of brings us into cross-reactivity, which I'll just briefly touch on. In order to understand cross-reactivity, we talk about the various beta-lactams. And so beta-lactams are a group of antibiotics that essentially share a core ring structure. They all have a beta-lactam ring within their chemical structure, and then they're further differentiated by the various side chains that they have. So our beta-lactam antibiotics include all of our penicillin, so amoxicillin, cloxacillin, piperacillin, etc. It includes all of our cephalosporins, our monobactam, and all of our carbapenems. These are all of our beta-lactam antibiotics. Now, when we talk about cross-reactivity, specifically, cross-reactivity between penicillins is a class effect, and this is what Dr. Fong had alluded to earlier. So what this means is that someone with a true penicillin allergy, the direction is to avoid all penicillins. And this is because the antigenic properties are due to similarities in that core ring structure rather than similarities in the side chain. On the flip side of that, cross-reactivity between cephalosporins is not a class effect. So someone with an allergy to a specific cephalosporin, a different cephalosporin or a beta-lactam with a different side chain can safely be used. And this is because the antigenic properties are due to similarities between side chains rather than that core ring structure. Cross-reactivity between penicillins and cephalosporins is primarily due to, once again, similarities in side chains and not that core structure. So someone with a true penicillin allergy, a cephalosporin or a beta-lactam with a different side chain can safely be administered to that patient. And of note, cefazolin is a cephalosporin, and it does not share a similar side chain with any other beta-lactam commonly used in Canada. It's a very unique structure, and so the only time we would avoid cefazolin is if a patient is reporting an allergy or a reaction to cefazolin specifically. So it is safe to use in other reported beta-lactam allergies. And then cross-reactivity between penicillins and carbapenems is very low, less than 1%. So if you're wanting to know and curious which beta-lactams share similar side chains or structures, if you go onto the First Line app and Under Resources and Tools, underneath Penicillin Allergy Delabeling Tool, you'll see the penicillin and beta-lactam allergy management, and there's a section on cross-reactivity. And so you click on the penicillin or the beta-lactam that a patient is reporting an allergy to, and so we'll use amoxicillin in this case as an example. So you click on amoxicillin, and it will outline all of the beta-lactams that share a similar structure to amoxicillin and have a risk for cross-reactivity. So these are the agents that would not be safe to use in this patient. And then it also provides you all of the beta-lactams that have different chemical structures with little risk for cross-reactivity and would be safe to use in your patient. So to wrap up the presentation, some take-home messages. You know that about 10% of the population report a penicillin allergy. However, less than 1% of the population are truly allergic. And we know that there's real risk and harm if a patient is mislabeled with a penicillin allergy. So it's important to have those allergies reassessed. And there are helpful tools that can help with that reassessment, specifically the first line, or in first line, there's a penicillin allergy delabeling tool. Direct oral challenges are very safe in patients with low-risk penicillin allergy. And if found to be non-allergic, it's very important that we're delabeling patients and removing that penicillin allergy from their profile. And if we're delabeling them in hospital, trying to communicate that to their community care providers is also very important, and making sure that the patient understands now moving forward that they can safely take penicillin. So that's the end of our presentation, and we'll leave some time for questions. I'll maybe open it up to the audience first, and if there aren't any questions, I know I have a question for Dr. Fong.
Thank you both very much. It looks like there's some questions coming in the chat already, so I'm just going to stop the recording.